All right, in this video, I'm going to cover three fungal infections from three different genera. So there's the Coccidioides, the Paracoccidioides, and then the Talaromyces, which actually used to be known as Penicillium. But if there's something that you might have noticed by now about microbiology, the nomenclature of microbiology frequently changes, and never is that more clear than when we're dealing with mycology. As I mentioned in kind of the self-study for the foundational material for mycology, there's even problems where organisms were named based on their yeast form and then given an entirely different name for their mold form, and then we found out once we had genetic sequencing that, oops, those are the same organism. So trying to rectify some of that has caused some problems, and one of those would be Penicillium, which is now actually Talaromyces. Okay, so the first group of organisms I'm going to talk about are the Coccidioides. Like many of the other infections that I've talked about in this series of videos, these are dimorphic fungi, and you can actually recognize them in the tissue based on their yeast shape. It's fairly distinct. So it's described as a giant spherule that contains endospores, and that's what I'm showing you here is kind of a cross-section in the tissue, and you can see this egg-like structure is actually the giant spherule, and each of these little clear dots in here are endospores. So what happens is that this spherule contains endospores, and the endospores multiply until the spherule becomes full of the endospores. And then eventually the spherule will burst, releasing the endospheres out, which can then set up new giant spherules, which will then get full of endospores and burst as the initial one did. Coccidioides is a disease that we don't see in Chicago typically. We predominantly see Coccidioides in the southwest United States. There are two species, Imidis and Coccidioides. They both cause the same disease patterns, and they don't differ in how we treat them, so you can kind of think of them the same. I do mention that just from like an epidemiology point of view, if you're in California, it's likely Imidis. If you're outside of California, it's likely Coccidioides. But that's kind of semantic because, again, the disease is the same and the treatment is the same. It is endemic to the desert, and when we think about it, you can actually kind of think of the life cycle of this. It's only found in the Western Hemisphere and largely only in the US. And we're going to find it in the soil in the Sonoran Desert, the San Joaquin Valley. Most cases of cocci are found in what we call the cocci corridor, which is really the space between Phoenix, Tucson, and Scottsdale. So kind of this area actually where there's a lot of development happening there in recent years. It's kind of like all of the people that used to snowbird in Florida are now transitioning to snowbirding in Arizona. So when we see cocci in Chicago, it's actually because it's exported, right? It's almost like a travel case, like when we were talking about the malarias and the dengues. So you've got a person who snowbirded, spent the winter in Arizona, and then came back and said, yeah, you know, I've had this cough and intermittent fevers for the past couple of months. And then we diagnose it here, even though they didn't acquire it here, because it can be kind of subacute or indolent. It likes to grow in the desert, desert soil. And sometimes you'll see it go into like northern Mexico as well. But that's pretty much where we're going to see it. There is something called non-endemic infection. It's fairly rare. But one of the things, you've got these endospores are very tiny. And when they get picked up, that's how we get infected. So these spores can actually be blown really easily, but they can also stick to things easily. So with non-endemic infection, that's where we have spores exported from the southwestern United States to other places. So they might become attached to the surfaces of fruits and vegetables. So, you know, on, I don't know, like some avocados that you took from California that then you somehow inhaled the spores off of, or like a grape from Southern California, maybe you didn't wash it well enough, and then you brought it home. There are also incidences of finding it on like leather goods or pottery. It's pretty uncommon, but it has been described. And one of the reasons this is possible is that the coccidioides are highly infectious. It really only takes one spore to lead to disease, to cause illness. And we see that actually also in the distance that it can go. So infection rates are actually higher after rainy seasons and dust storms. So when it rains in Arizona, that actually helps the spores grow and germinate in the soil. And then right after the rainy season, this dry spell hits. And in a dust storm, the spores get kicked up and they can be blown for miles and miles away, and then we start seeing disease. The same happens in an earthquake where the ground is disturbed. And one of the things that we're seeing kind of as part of global warming is that this desert-loving fungi is actually starting to move north. So we're starting to see cases in Las Vegas and Utah, places that we didn't normally see it. In 2001, there was actually a decently sizable outbreak at Dinosaur National Monument, where some of the archaeologists digging there actually got sick. So clinically, most people who become infected with cocci are not symptomatic if they're otherwise healthy and have a low spore burden. At most, they'll get kind of a flu-like illness. And remember, flu-like illnesses are somewhat hard to quantify, right? Because you could have been exposed and had this flu-like illness, and then you got over it. So you never sought medical attention, so we're never certain that you actually contracted it or had any symptoms to it. But most people are asymptomatic. The incubation period for this one is actually very short. It's only about 7 days or so. And I don't think I mentioned incubation periods for histo or blasto, but they're actually fairly longer. Histo is about 2 to 3 weeks, and blasto is 4 to 6 weeks. But with this one, 7 to 14 days, and patients will start showing symptoms. And the symptoms are also kind of nonspecific. You get fever, dry cough. Sometimes we see like pleurisy, associated with inspiration or coughing. And the only kind of indicator that you might get here is that in about 10 to 15% of people will see eosinophilia. And so they'll actually show kind of this increase in these cells that are trying to fight this large pathogen. And that's pretty unique to Coccidioides. We don't tend to see that with histo or blasto. There is kind of an immune reaction that is an immune manifestation that's associated with cocci, and that's desert rheumatism. We see this more often in young women. It usually manifests about 2 weeks into the illness, and it's really just kind of this nonspecific fever, arthralgia, so sore joints, and then sometimes they'll develop erythema nodosum, which are these painful subcutaneous nodules that you see with like sarcoid, or sometimes erythema multiforme. It's important to note that these are actually immunologic reactions. So these are not a sign that the infection has actually spread extrapulmonary. It's immune mediated. So it's entirely based on the host inflammatory response, and it usually resolves spontaneously. And actually, that's kind of the story with cocci. The infection typically resolves without sequelae if you're an otherwise healthy individual. So for mild cases in an otherwise healthy individual, you're not going to treat. There's really no need to, because they'll just clear it and it'll be okay. But we do have patients who will go on to develop a chronic pneumonia. Chronic pneumonia or disseminated infection can also happen. This is typically going to be in somebody who is, for some other reason, not healthy. They might have diabetes or be a smoker or have some other underlying condition that is affecting them. And then you'll see the chronic pneumonia that we've talked about with other conditions. Extrapulmonary dissemination in this case is very, very rare. We don't see it very often. It's like less than 1% of all cocci cases, which cocci is also fairly rare. But there are some people who seem to be at slightly higher risk. Men are more likely to experience an extrapulmonary dissemination than women. We don't really know why. Pregnancy, especially as you move into that third trimester and we see a little more suppression of the cell-mediated immune response, that certainly is a risk factor for disseminated cocci. Certain ethnic groups also, specifically Filipinos, Native Americans, persons of African descent. Again, we don't really know why. We think it has something to do with genetics, like a change in HLA alleles. But yeah, that's where we might see an extrapulmonary dissemination. And when you see extrapulmonary dissemination from cocci, you really need to worry about the CNS. It has a particular predilection for the CNS where it causes meningitis. As far as diagnosis goes, culture, once again, the gold standard. I feel like a broken record saying that. You can also do identification of the giant spherules with the endospores, because as I talked about up here, it's very specific to this particular organism. It is pretty hard to grow this in culture, so that's why the direct identification is helpful. There are also serologic tests, so you can look for anti-cocci antibodies in the serum or the CSF, which is especially helpful when you're dealing with chronic pneumonia, right? Because we need time for those antibodies to build. So in that case, you can look for IgM or IgG in the CSF there. Treatment, like I said before, for your average healthy individual, it's most likely going to be self-limited. You might not need to treat, but you will treat moderate to severe pneumonias or disseminated infections with these drugs. The only thing that when we think about this, where you might treat a mild case is if the patient has something else going on, if they're immunosuppressed, if they have diabetes, something like that. And then there is kind of a special case, as I mentioned above, when it disseminates, it does have this predilection for the CNS. And if it gets into the CNS, where it can cause meningitis, it is believed to be uncurable. So at that point, you're going to need to treat the patient lifelong. They will constantly be on an antifungal to control their cocci infection. Okay, so Paracoccidioides brasiliensis. This is another dimorphic organism. The yeast form has kind of this unique spaceship looking shape, or like a captain's wheel shape, where you have the spores kind of surrounding the mother cell here. If you cover up like these two down here, it can kind of look like Mickey Mouse ears. We don't really see this one in Chicago either. This one's endemic to Latin America, and as the name kind of implies, mostly to Brazil. And there it actually correlates or parallels with an increase in HIV that we're seeing in Brazil. So it's now largely considered an opportunistic infection in persons with HIV, where it actually has become kind of an early indicator of an HIV diagnosis. Prior to the HIV epidemic, other risk factors that were considered were like malnutrition or alcoholism as a potential reason that a person was at higher risk for developing these infections. But now it really is associated with HIV, especially in the big cities down there. The clinical syndrome is very similar to some of the other organisms I've talked about, particularly histoplasma. Once again, you're going to talk about this chronic pneumonia, which can be disseminated. And when it's disseminated, you're going to get kind of some of these ulcers, so the oral ulcers, but also these warty skin lesions. And if you look at this patient over here, these lesions don't look that different from the skin lesions that I showed in the histoplasmosis video. You can also, it can go into the bone marrow, so you can see this pancytopenia. It can affect the adrenals. You see the adenopathy. The interesting thing about this one is that it does potentially have the ability to reactivate later in life, which once again kind of makes us wonder if the immune response is actually capable of fully eradicating it. You should use culture to identify it if you were to ever come across it. It's fairly unlikely in the US. You can also ID the yeast forms in the tissue, and here are the appropriate treatments for it. Okay, and this is the last one I'm going to talk about in this video. This is Talaromyces marneffii. It was used to be known as Penicillium, but now it's been renamed. Most of the cases that we associate with Talaromycosis are actually coming out of Thailand. and Southeast Asia in general. That's kind of the most commonplace. And once again, just like the Paracoccidioides, it kind of correlates with new identification of HIV infections, especially in the big cities. One of the kind of difficult things about Talaromyces is that we don't actually know where to find it. We think it's inhaled from the soil, but the actual identification has not been made of what its actual reservoir is. For a while, the bamboo rat got kind of a bad rap that maybe it was the source of it, but that's been ruled out. So now we're not really sure, but it makes sense for it to come from the soil in these endemic areas. Once again, that clinical syndrome is going to resemble histoplasmosis, fever, cough, pneumonia, lesions, which you can see here, and it can also get into the bone marrow. We can see kind of a primary infection, certainly with Talaromycosis, but the bigger concern is that it might be able to reactivate. So kind of like TB can reactivate as a patient gets older. We think this one can too. The first kind of incidence of this was actually reported in 1974 when a patient with lymphoma was having a splenectomy because he had splenomegaly, and they thought that the spleen would rupture. But when they removed it, they actually identified Penicillium in it. And when they questioned the patient, it turned out that the patient had been a missionary in Vietnam years and years, even years ago. So we think that, as he got older and had cancer, that the body was no longer able to control it, and it kind of reactivated its growth. So this is also something to consider, like if you're treating like a Vietnam vet, that they might have acquired it there years ago, but now as they age, it reactivates. It has a very specific yeast structure. Looks kind of like a cigar with a transverse septum, a line down the middle, or like a pill. And that's the reason for this is that it actually divides by binary fission. So this one doesn't bud, it divides. It divides itself in half completely. Culture is the gold standard, but again, we can always identify the yeast form in tissue, and here are the appropriate treatments for it.